Abiraterone and prednisone have essentially the same label indication as enzalutamide, and that is for men with metastatic castration-resistant prostate cancer, whether it's symptomatic or not, whether they've received docetaxel chemotherapy or not. So because those drugs share a very common label, they're frequently compared to each other. And the fact is that when we look at the studies that led to their FDA approval, the phase 3 studies, they're pretty similar in terms of overall survival, in terms of the progression-free survival, in terms of PSA. A couple of things that differ between those studies. The enzalutamide studies included patients with visceral disease. So for our patients with, say, asymptomatic visceral disease, we'll sometimes favor enzalutamide in that population. Abiraterone was done with prednisone. So for some patients, even low doses of prednisone can be difficult to tolerate, particularly diabetics. Overall, these drugs have a very similar and well-tolerated side effect profile, but we did see a little bit more incidence of cardiac events, low grade typically associated with abiraterone prednisone than with enzalutamide. So for patients that have a cardiac history or a significant problem with diabetes, tend to favor enzalutamide. Enzalutamide, though, was associated with more falls, particularly in our patients who are older, 75 or older. So for many of our older patients or slightly frail patients, we might consider abiraterone and prednisone for those patients. So they're really both good options. I use both drugs in overlapping indications, but those are some of the factors that will push me towards using one agent over another. Abiraterone prednisone is a standard of care for patients with metastatic castration-resistant disease. And in this particular case that we presented, the patient had symptoms with some mild migratory pain and fatigue. Now you could argue those are mild enough symptoms, maybe the abiraterone alone could manage this. But remember, this was a rapid natural history. This patient went from localized disease to a couple years later, rapid PSA rise, to a couple years later, hormone refractory or castrate resistant and widely metastatic bone metastasis. So I would argue that's a natural history that's rapidly progressing, and this is a patient who's at risk for developing resistance to abiraterone sooner rather than later. Remember also, this is a case where a patient has limited treatment options following the abiraterone. It makes sense to say, is there a way to administer additional therapy sooner rather than later? The advantage of doing that with radium-223 is that it takes a while to get this in. It's a 5-month therapy. It's monthly injections times 6. So you've got a long course to get through with that, and you've got a patient whose natural history has been progressing in bone relatively rapidly. So to me, it makes sense to say, hey, let's not wait for this patient to become resistant to abiraterone. Let's move that radium-223 up. It's actually on label as well. If you look at the label associated with radium-223, it's for symptomatic patients, even minimally symptomatic patients. It's for patients with bone-dominant metastatic castration-resistant disease, which he has, and it allows standard of care, best supportive care, which you can argue in this case is both his LHRH agonist therapy as well as his abiraterone prednisone. So for me, this is on label, sensible, a little bit kind of proactive and aggressive approach to managing this patient with an otherwise rapid natural history of disease.
I think one of the most interesting things about this patient was the presence of the imaging findings that were seen then and not seen prior, and also the rapid elevation in their PSA up to about 150. The presence of bony metastatic disease on both the CT and the bone scan, and also the absence of visceral or lymph node metastatic disease is a helpful thing, and I think it helps to inform some treatment decisions. So that's sort of my impression of the patient, was just the rapid progression of their disease from where they were after the radical prostatectomy and where their PSA had natered out to less than 0.1 to all the way to the point where they're at the PSA of almost 150. The concept of radium-223 is that it allows you to really attack the bone mets, and I think here the imaging informs the decision-making a little bit as well. So we don't have any visceral mets, we don't have any solid organ mets, our disease is really confined to the bone. And so this makes radium-223 a potentially attractive choice for this patient.